Good morning, everybody. Thanks, Dr. Ahmed, for the great presentation. And actually, early onset is a burden for any spine surgeon, and sometimes you feel helpless and hopeless when you're dealing with them. Shortly, they submitted all the all types of deformity below 10 years old to be early onset, whether it is idiopathic, congenital, syndromic. And when you are going to go for surgery for those patients, you have a target is a stop progression, because as you see, some cases are progressing and you can face mortality, just not morbidity in those cases. Maximize the thorax volume to allow cardiopulmonary growth and avoid respiratory and cardiac diseases. As you see here, up till age of 8 years and 10 years, just 50% of the growth of the thoracic cage is will you achieve until age of 8 or 10. Acceptable correction and preserving spinal growth. For sure, the non-operative is the best if it's applicable, like casting, to avoid surgery with all the complications that we face. And the aim of surgery is to remodulate and avoid surgery and improve the pulmonary function and the cage volume. Surgical techniques can be summarized in 3 types, either distraction-based, compression-based, or growth guidance techniques. There are some pivotal stations in the history of growing systems. Harrington rod, since 962, was a technique used for growing. Then the Luke trolley, sorry, the animation is wrong. And Roy Camille with the pedicle screws that improves the result, avoiding the hooks and wire issues. Then McCarthy and Asher for the Sheila technique. Also, Dubussy was one of the important for pedicle screws and describing the crankshaft phenomenon. All of the techniques that we are going to discuss are, the main complication is the crankshaft and failure of the system. Sanders focused about the razor zero and open trajectory as a population at maximum risk of crankshaft. DiMeglio has identified the 2 peaks of growth at 0 to 5 and 11 to 15 years. And Winter have a very important study because he used the convex side avoid progression to identify how gross reduction you will lose with fixation. For the distraction type, we have the chest wall distraction like the Vector. It can be used in thoracic insufficiency, skeletal immaturity, and the congenital. It contraindicated in skeletal immature, poor rib, and absence of ribs. And the other thing is traditional growing rod in early onset and neuromuscular and scoliosis, and is contraindicated in the mature, skeletal mature. However, complications are high for the growing growth system as infection, up to 70%, rod breakage, and supine stiffness. Or for the Vector technique, you have multiple surgeries for infection, the lift of the device, and chest wall stiffness. Traditional growing rod is based on upper and lower actin. It is distraction based, limited control of the apex with the traditional facing the crankshaft phenomena, and multiple surgeries with good cost and complication as we mentioned. Convex growth arrest, hemiepiphysiodesis, like Winter used to use, either using just decorticating and fusing the convex or using fixation. But the issue of this technique is the unpredictability of curve correction has prevented. So sometimes use the hybrid technique with the growing rod. So in summary, the large 3D residual deformity at the apex make all the systems have many problems. Worse curve correction, less spinal growth, high complication rate. So the growth friendly tried to avoid this complication, either distraction baked like the magnetic control, but it's extremely expensive. And now there are many debate about the usage and how it is sometimes logged and failed after time. Compression based like the APC technique, and the growth guidance like Sheila and the APC. The Sheila technique with McCarthy have used a criteria that you have maximum number of growth center preserved. Will you fuse segment go for more normal, the ultimate mobility? The deformity works as the apex, so when you have good correction as the apex, you will avoid many complications. And the uses of pedicle screw is superior than using the other ankle like the hooks. It is a clinical and still used up till now in many centers all over the world, but even there is 2 major complications. The crankshaft phenomenon is 62% and adding on or migration. Even his paper in the literature, McCarthy and his colleagues found that the complication is present as the crankshaft and the migration. So Dr. Ala Azmi have an innovation or modification of the Sheila technique with using the apex control by using the apex for wedged vertebral fixation, non-fuse correction, and derotation. And I see that the derotation is one of the most important issues to avoid complication. It is a hybrid guided growth and posterior testing philosophy, replacing traditional Sheila with apex non-fusion and growth modulation through unilateral compression, translation, and rotation of the convex side associated distraction on the concave side. The biomechanics of the APC that allowed compression-based intervention of the apex in accordance with the Hotel-Volkmann law, and this reverses the modulation so the wedged vertebrae become normally growing and restoring is the normal rectangular shape with time. At the same time, the derotation avoids the crankshaft phenomena. So the technique, as Dr. Ahmed mentioned, you identify the apex and you put 2 screws, one above and one below. Then you apply anchors up and anchors below. Then connect the 3 rods on the convex side with mobile domino. And on the concave side for distraction, you apply another domino with distraction. You keep about 4 centimeters in length to give opportunity for the growth of the rods. Then at the apex, at the concave side, you do distraction, and as you see here, you keep the domino on one of the sides. The domino is free from screws to help the patient grow smoothly. When you compare it with other techniques, it is safe and easy to perform, and implant are relatively inexpensive. Rate of facet fusion with APC is still under study. There is a very nice paper presented from Dr. Ala and Dr. Yahya from Egypt here that they show that the fusion at the apex is very minimal in 1 or 2 cases in their study, and still for sure this technique needs follow-up. I will show just 3 cases, a 7 years old early onset juvenile idiopathic with a curve 49 degrees and there is about 82 degrees kyphosis. We achieved do APC technique with significant improvement in the curve. As you see here, I still do using 1 skin incision, but for sure I use the intermuscular Wilsey technique, applying screws whether in the upper or lower ankles, and I keep the muscle and I try not to touch the bone. And here is the patient post-operatively. The tip of trick is this: using derotation instruments at the apex will give you a very good correction. Another case with thoracolumbar curve 55 degrees and 87 degrees kyphosis, and the patient also improved acceptably post-operatively. This case, the last case, is 4 years old, juvenile idiopathic early onset, 72 degrees and 55. I did all my case the idiopathic. I didn't try not yet congenital or syndromics, and thoracic kyphosis 55 degrees, and the patient show significant improvement post-operatively. So my conclusion: safe and viable option is the APC in surgical management of early onset, effective in reversing modulating apex wedging. Short-term outcome is promising. Future long-term studies are needed for better understanding of clinical and research outcome and their sustainability. Appropriate selection of candidate is fundamental. Thank you very much.